What if your EHR isn't actually helping you think, but quietly overloading your brain? A 2024 narrative review in the Medical Informatics Journal dug into EHR's cognitive load and burnout. So here's the deal, right? Your working memory is tiny, and we're talking maybe 3 to 5 chunks of information at once, tops. And in cognitive science, there are 3 flavors of load. First, you have your intrinsic load, which is baked in the complexity of the task itself. Then you have extraneous load, which is how the information is presented. Things like the user interface, alerts, click-fest menus, right? And third, you have your germane load, which is the mental effort of building useful patterns and mental models. The problem is that EHRs mostly crank up the extraneous stuff, cluttered screens, duplicated data, alerts that never quit. Now, imagine trying to finish a note, but the default display is disorganized. Every ding from your inbox feels like a potential lawsuit if you miss it. Inbox and alerts are huge drivers here. Interruptions, fear of missing something important, uh, that constant low-grade tension that already permeates healthcare delivery, but then you add the pings and the dings and all the things that the EHR brings. And then there's what researchers call information chaos. It's not just overload, but also underload, scatter, conflicting info, outright errors. Around 4,000 clicks in a single 10-hour ED shift, according to one community hospital study. In the PICU, each patient generates 1,460 new data points per day. Attendings face tens of thousands every night. Nurses in one study spent about 46 minutes on the EHR every 4 hours, with stress signals spiking while charting. Burnout across specialties runs about 22 to 34%. And if you're charting after hours, 6 or more hours a week, your odds of burnout roughly double. One large survey found that 70% of clinicians reported some form of EHR-related stress. And how do they measure load? Right, they have the NASA TLX questionnaires, blink rate, tracking, and even physiological symptoms or signals. So what's actually helping, right? We have things like alert stewardship, measuring alert value, setting interrupt budgets. You have inbox redesign, such as triage rules, batching non-urgent items, cutting those endless FYIs, random CCs, right? Documentation support, smarter templates, targeted training. Scribes can help too, but cost can be a hurdle for a lot of people. Workflow tweaks, reducing the number of clicks, building single screen summaries. I like single screens. All the clicks are not are detrimental to attention, right? Automating data entry, improving visualizations, and better interoperability. So because the less you have to hunt for missing info, the better your brain feels. Making the EHR prettier doesn't fix the burnout itself. I remember comparing 2 EHRs side by side. One had a modern interface, all right, with all the nice buttons and flat and then the other one had the old style interface, but they both had the same intrinsic experience, all right, the same clicks, the same navigation, the same philosophy or theory or core principle for how the workflow should work or shouldn't work, all right? Burnout is also about, workload, culture, staffing, work-life balance. Technology is a lever, but not the only one, right? And then the paper that we're discussing also calls out some big gaps. There's no standard validated metric for documentation burden or for EHR-specific cognitive load. We need better objective measures beyond just surveys. And specialty differences are real, so one size fixes don't cut it. If you want to start somewhere, track a simple scorecard. After hours, minutes, for instance, alerts per encounter, message backlog, note length versus unique data, right? Copy paste rate, or maybe a NASA TLX pulse, right? Monthly. And just to suggest some quick wins for you, right? Look at your inbox hygiene, triage and batch. Kill auto pop bloat and timestamp copied text. Third, you can have an alert amnesty. Turn off the bottom quartile and only re-add with evidence. EHRs aren't going anywhere. They may be changing qualitatively with the advent of ambient scribes and AI tools. But the principle remains that the real win is shifting from more data to better presentation, more workflows aligned with cognitive processes that don't try to break them, that don't try to re-engineer them, but that try to align with existing cognitive processes so that the working memory isn't the rate limiter, but that it's supported.